Welcome everyone to tonight's second Young SIOPE webinar. It's a pleasure to see all of you here, and it's thank you for joining us today. My name is Roelof van Ewijk. I'm a clinical research fellow in pediatric oncology at the Prinses Maxima Center in Utrecht, and I'm one of the members of the steering committee of Young SIOPE. It's a pleasure to moderate this session today together with Paula Perez. Paula is a pediatric oncologist at the University Hospital Central de Asturias in Spain. She's a pediatric oncologist and she helped to coordinate these webinars. I'm so honored that Professor Baruchel and Professor Bader are present here today to discuss such an important topic on CAR-T cell challenges in acute lymphoblastic leukemia with our Young SIOPE community. CAR-T cell therapy has provided an option in previously untreatable leukemia and becomes more readily available. And today we will discuss some important challenges in bridging the patient to CAR-T cell therapy and the role of bone marrow transplantation after CAR-T cell therapy. After an introduction, we'll discuss some cases. And what I would like to ask you today is we aim to provide an interactive meeting. So please, if you raise questions, put on your screen so we can see you and we can interactively discuss with each other on this interesting topic. What we would like to ask is that you mute yourself while others are speaking, but if you've got a question, please use the chat to say, I have a question. You don't need to spell the whole question. We will give you the mic and then we'll ask you to pose your question and we can discuss it. With that, I would like to hand the word to Paula to introduce our speakers of today.
So thank you, Roelof, and thank you, everybody. Welcome to the webinar. I'm happy to present the two speakers for today's webinars on CAR-T cell challenges. First, Dr. André Baruchel. He's the head of Pediatric Hematology and Immunology Department at the University Hospital Robert Debré in Paris, and also a professor in the Université de Paris. He's the leader of the French acute lymphoblastic leukemia group and a member of the ITCC Consortium Executive Board. And lately, he has been focused on CAR-T cell therapy in children, being his hospital the first French hospital with the approval for this therapy in children. And then we will listen to Dr. Peter Bader. Dr. Bader is a professor of pediatrics at the Johann Wolfram Goethe University and the head of the Division of Stem Cell Transplantation and Immunology and vice director of the University Children's Hospital in Frankfurt, Germany. His research is focused on preventing relapse after stem cell transplantation in children with malignant diseases, and he has a huge experience in CAR-T cell therapy in children. So thank you both for joining us, for accepting our invitation, and for sharing your knowledge and your time with the young pediatric oncology community. Just to introduce the webinar, first Dr. Baruchel will start and will lead us through some of these challenges on CAR-T cell therapy in children with acute lymphoblastic leukemia. And then Dr. Bader will share some interactive cases on which they will both discuss, and on we also invite you to ask questions, as Roelof said, writing it to the chat. So now, thank you very much, both. And now I will give the word to Dr. Baruchel.
I hope you really hear me well and that the slides are well seen also.
We see and hear you well.
Thank you very much for your committee to invite me and Peter to this very nice session. It's always very interesting for us to interact with the younger investigators who will replace us in the long run and maybe in the short run anyway. So the first subject is about how to bridge to CAR. You know, we all use this word bridge, but is it a golden gate or much more difficult way? We will see some hints. Here are my link of interest, and I put in bold the one with the CAR-T cell manufacturer, Novartis, Servier, Celgene, and Kite, and the other ones are related to drugs used in the field of ALL. So just a brief introduction. Why do we do CAR? Because we still have remaining problems in ALL. The first one is that despite the survival, which is over 90%, you know that approximately 10 to 15% will relapse. And this relapse rate of 15 is kind of a mean between infants, where progresses have been particularly slow, adolescents where progress have been made but still are a problem, and adults are still also a problem. And transplanters like Peter know that some relapses, even with transplant, are rarely curable, particularly 119, 1719, hypodiploid, and P53 mutated B-lineage ALL, and of course TLL, which is not the subject of today. Overall, I would say that we are not satisfied with the prognosis of relapsed ALL. In terms of toxicity, also it's very strange now that you know, you are too young to know that, but the aphorism made by Steve in the US was that more is better. The problem with more is better that now we know that we have in some groups a very good prognosis, as many deaths in CR that we have relapses. On top of this, we are used to manage adverse events, but they are not normal. It's not normal to have bald children, and it's not normal to be transformed by steroids. And you know that the more intensive and the longer the therapy, the higher the burden of therapy. And at the top, of course, transplant with all the TBI-related effects. So we need something else. So the something else came as a principle in '89. It was the left side of the panel, where Israeli researcher Zeli Gesher had the idea to transform the specificity of a T cell with the recognizing domain of a B cell. So that's why it's named chimeric antigen receptor. And I hope you can see my pointer. Here is the binding domain. For example, here it is anti-CD19. And inside the membrane, the information you will give the cell through gene transfer will be, for example, the CD3 zeta chain, which is a co-stimulation molecule. This didn't work. And finally, it was because of the invention of Dario Campana and then transferred to SIOPE in Philadelphia and Carl June, that the idea to, and Michel Sadelin in New York, the idea to transfer one other co-stimulation domain, either CD28 or 4-1BB. And here is, for example, what is sold as Yescarta in adult lymphoma and tried at the moment in childhood ALL. And this is what is sold as Kymriah of the Novartis, which is with the 4-1BB. So these CAR are different. They are different in terms of speed of expansion and persistence. And what we know now that expansion is extremely early, rapid, and powerful with CD28. And it is slower, but rapid also, but associated to long-term persistence with the 4-1BB. And this is probably very important if you think of replacing some other therapies with this kind of technology. So in this slide are summarized the response rate in children and adults. And as you can see in the fifth column, there have been so many data published yet, apart from the real life data which begin to appear, in terms of there were no comparative trials. These are monoarm trials, and 30, 21, 45, etc. And yes, and you can see that whatever the vector, gamma retrovirus or lentiviral, whatever the co-stimulation molecule, whatever the age, and there are few adults here in these slides, The overall response rate, which can be measured depending on the study at day 28 or at month 3, the overall response rate is around 80, let's say 80%, which is absolutely extraordinary for very advanced disease, which have been the subject of all these studies: second or more relapse, refractory disease, relapse after transplant, and so on. As you can see, the conditioning regimen was not the same in all the study, and the selection or not of T-cell was not the same in all the study. In terms of toxicity, this high response rate has a price to pay, and the price to pay is so-called cytokine release syndrome and neurotoxicity, or CRESS or ICANS, depending on the paper you read. And as you can see, the rate of CRS can be as high as 100%, 27% severe in this study, 46% severe in the Liana study, with approximately half of the children going to ICU at that time, and in different CAR-T cell, less severe reaction. But in terms of neurotoxicity, the neurotoxicity is generally milder with the 4-1BB, 13% severe here, the lowest one, 40% severe in the CD28 adult trial by J. Park in Memorial Sloan Kettering. This is the famous curve which has been actualized by Steve Grupp at ASH 2018 out of the Eliana trial, where Peter and I have participated too, which has included 79 patients. But these 79 patients, you must realize, are the infused patients. 93 patients, in fact, have been included in the study, and only 79 make it until the infusion. And these curves are very nice for very advanced children with 62% relapse-free survival. You can make a very wrong statement and say that approximately half of these children will be cured, and a lot, if not all, because only 8 children in this series have been transplanted afterwards. Most didn't need a further treatment after the CAR-T cell, which is absolutely extraordinary. But if you want to try to read the literature, you have to recognize that there are immense differences between trials, companies, and papers. Concept and manufacturing of the CAR-T cells are very different depending on the vector you use, lentivirus, retrovirus, now non-viral methods. Second or third generation, co-stimulation domain, as I said, monospecific versus bispecific CAR. We will have bispecific in the near future. The lymphodepletion, which is everybody that say we do flu-cy, but some did 75 milligram per meter square of flu, cumulative dose. Some of the trial come up to 150 flu. And same for cyclophosphamide, ranging from 500 to 3.6 grams per meter square in the allergenic setting CAR-T cell. So the composition of the living drug varies, but what we have to discuss today is that the bridge to CAR are not homogeneous along the studies, and the treatment post-CAR, transplant or not, are not the same along the study. And of course, clinical trial versus real world is another issue. I will not talk about that today. Again, coming back to the slide of Eliana, I have showed you, you could see that 97 patients have been enrolled out of 113 screened, and only 79 were infused. And what happens to the other 18? Manufacturing issues that you can think we can do better, and Novartis think they can do better now than this, but 10 patients died or had adverse event preventing the realization of the CAR-T cell procedure. So how to manage this bridge? So I have put on this slide some facts about bridge. First one is that the interval between apheresis, if we speak about autologous CAR-T cell, and the infusion is of variable length. The current range is in the 3 to 4 weeks with a commercial product, but it has range in the clinical trials until 3 months. So you can imagine you have a child with a very advanced disease and you have to maintain him or her for 3 months prior to infusion. This time is probably shorter in academic closed system using fresh cell and decentralized production. But also many variables influence this interval beside the manufacturing. The cryopreservation to shipping. Sometimes you send the cells to your department of cell therapy, but the cells are not picked immediately by the manufacturer. The manufacturing can be done within EU or outside EU, depending on the slots. So you can imagine that it's longer if you send it to United States. The availability of your cell therapy lab, which now are overwhelmed with adult lymphoma and myeloma in the years to come, will be a problem for our small population of ALM. And as you know, now it's a drug, so pharmacy also is involved. You need to have a room in your department. You need to have a common availability to send you the drug by the cell therapy lab and the pharmacy. And also you have to recognize that epidemics or pandemics limit the number of beds in ICU. And you have to realize that maybe you will be in the 20 to 40% of patients who will need ICU. But at the end, the clinical status also of the patient is of utmost importance, because the main risk of the bridge is the infection and also the effects of the therapy or the immune therapy. For example, I know that you would use during this bridge to CAR-T cell, but the biggest risk, and I will show you an example for if we have time, is the disease progression. We are talking about extremely aggressive disease in a number of the cases, and this disease can progress despite of any bridge you want to perform. So the art of bridging, if I can say like this, is choosing the best chemo with to me, it's one of the most difficult things in the field now. We have learned how to deal with CRS, with neurotox, and so on. Even some cases are difficult, but you do not control everything for the bridge. So you have to be very experienced and to discuss with the most experienced people in the field in your department to say, how can we control this disease? Looking at disease biology, looking at the history of tolerance in the past of the child with this disease and with the treatments. So there is no one size fits all, and targeting to undergo the lymphodepletion plus infusion without too much disease. This is the target. But what we don't know is, do we target for 0 or do we target for some? It's still an unsolved question, and it will be an interesting topic to discuss with Peter today. And monitoring, you have to realize also that when you do the apheresis, then you send back the child to his city. So generally, you have to monitor during 1 month or 2 months a child which is not in your unit, even if you are the strategic decider. And this means that you have to have a close collaboration with numerous contacts, at least 2 per week in our experience, with a referring center. So these are examples. There is no religion, no truth in this domain. These are examples of possible choices. It happens in one case with very long, very smoldering disease that we did no treatment at all, and it worked. In most of the cases, we do low intensity chemotherapy. And the more we go, the more we do less, I would say. And at the moment, I have put in yellow what we use a lot, which is a simple association between weekly vincristine, 2 days of DEX per week, which is the regimen that the adult with Ph positive ALL use. But we don't do, of course, TKI, except it's a BCR Abelson. You can also say, and we try to measure disease after 2 weeks so that we know if the disease is progressing during light chemo or not. So measure what you do is also a very important message. In terms of intermediate intensity, some do the equivalent of the consolidation 1B of the BFM. We propose, and I will show you an example, a very light vincristine, dexamethasone, bortezomib, asparginase. I know could be used in some very resistant patient, but could result in MRD-neg patient with 0 normal B cells. So you could argue maybe there is no more target to expand. So is it desirable? We are not so sure of that. And finally, some disease need very aggressive bridging because of proliferation. So you can think of high-dose RSC, VP16 cyclo, hyper-CVAD if you are US. Also, we do more and more patients with CNS involvement, and sometimes this disease is highly resistant during the bridge, and high-dose methotrexate can be discussed. And in adult patients, we have had also the need to bridge with high-dose RSC immediately followed by lymphodepletion. So no time to go out of aplasia. In any cases, prophylaxis of infection and particularly antifungal infection in these very advanced patients with very advanced disease is of utmost importance. So this is the BVAD bridge we use sometimes, which is weekly vincristine, bortezomib day 1, day 4, day 8, day 11, dexamethasone fractionated, and pegasparginase for the patients who are not resistant who are not allergic to PEG or have not made CNS thrombosis or pancreatitis. There are very few literature. I have put you on this next slide, the recent paper published by the Memorial team after an abstract at ASCO. This is a very, I would say, very bad paper, but it is the only one we have on the bridge. It's not a well-written paper, and the conclusions are, in my mind, not so strong. Anyway, the idea was to characterize the bridging therapy applied in patients they have published as CAR-T cell therapy in the adult field for relapse refractory LL. This is the paper of New England by J. Parr. So they have done a retrospective study to look at how did we bridge those patients to the CAR. And they have divided the intensity in high or low intensity, depending on the dose and the chemo they have used in terms of myelosuppression. For example, hyper-CVAD was quoted as high intensity, and blinatumomab or TKI or maintenance chemotherapy was quoted as low intensity. I have put this slide, I have reconstructed it because what is on the left panel was only the supplemental data. And why I show you those supplemental data, because you see how biased are any publication on CAR-T cell. 94 patients screened, 84 analyzable for analysis of this retrospective paper. But the paper who were published in the New England were only those 56. So you can imagine approximately, I would say to be rough, half of the patients only make it to CAR. The other one, after the bridge, have choose an alternate treatment. Maybe it was a good idea, by the way. Transplant, DLI, alternate trial. And 18 were not infused because of progression of disease or complication. So when you look at the left panel, the right panel, sorry, from beginning of bridge, then you see that the real survival is not 50% or 40%. The real survival of this population for beginning at the bridge, so the 84, is a very poor one. And if you look at the the patients who didn't make it because of progression, the survival is null. If you look about the effect of the bridge in terms of survival, if you have a bridge response, the survival is better than you do not have a bridge response in terms of morphological persistence of disease. If you succeed to maintain a persistent molecular disease, it's like the same that a bridge response. In terms of, is there a difference between the patients with high intensity and low intensity in terms of result? The answer in this paper is no. But you could argue that the patients who receive the highest intensity have made the highest grade 3-4 CRS, which means that there were more severe patients despite of the comparison made by the authors. So more patients with high-grade CRS here than the other group. So the conclusion of this paper was, one, if you do high intensity, maybe you will bring the patient to CAR, but you will have more grade 3-4 infection. And finally, the results in terms of long-term results will not be so different. So some facts and questions you can find in the discussion of, again, this not very good paper are the following, and I think these are interesting and maybe more universal than we could think. The first thing is that a low disease burden prior to bridging is associated with overall survival. Peter has found this in his series. We have found this also in our series. A low disease burden prior to infusion is also associated with less toxicity. The reduction of disease burden by bridging is associated to favorable outcome. But why? You could argue it's a selection of a favorable subgroup of patients, or it means that the effective cytoreduction increased the efficacy of the subsequent CAR-T cell infusion. Interestingly, in this paper, it's shown again in supplemental, there is no difference in peak expansion or median persistence of the CAR-T cell between patients with disease at the procedure, with disease only measurable with MRD methods, or with no evidence of disease. So for this paper with CD28 CAR adult ALL, there is no relationship between the disease prior to LD and the expansion of the CAR-T cell. So this is what they propose, and I think that beside the fact that the paper was not so good, this is a reasonable decision tree. As soon as you have taken the decision to treat with CAR, you could say, if you make the diagnosis at a low disease burden, for example, a relapse that you have diagnosed very early and not progressing so much, you could argue in favor of low intensity or targeted treatment if you have one, if you have a target. At the contrary, if you have a high disease burden or extramedullary disease, you could look at the previous answers, the response to prior line, and decide between low intensity and high intensity. These, again, are only proposition, because the conclusion of this paper is essentially that no one size fits all, and it is an individualized decision. And I think this is important. It will be not so easy due to the rarity of relapses in pediatric ALL to make a uniform decision on a, let's say, protocol-based decision for bridge. But we will try. Maybe Peter, I will skip this one, and you will. I will give the hand to Peter, and you will see what we can. I will stop my sharing screen. Here is Peter.
But I think in the meantime, Professor Bauder can open his screen. There is a question to you already, Professor Bauschel, and I want to like to ask Pierre Gonsalves to put on his mic and his camera and pose the question. Yes, you can. We do not hear you well, Pierre. Otherwise, I'll pose the question for you.
Ishimo, I think, no?
Yeah.
Hello?
The question is, was it in the Perica publication used INO as bridge therapy? And what was the criteria to use it? And how would it result to the outcome?
No, they didn't detail in this paper, they didn't detail the use of INO. You will see appear probably in Blood, I think, a paper of their experience of the relapse after CAR, and then they detailed the use of inotuzumab, but in this one they did not.
Okay, thank you.
Professor Bader.
So first I have to unmute myself. Yeah, thank you very much for this great invitation to take part in this wonderful session together with my friend, Professor André Baruchel from Paris. And you put us difficult topics, first bridging how to deal with this to the CAR-T cells. And then finally, if CAR-T cells are doing the job or not, or whether they do still need bone marrow transplantation. And so when we discussed preparing this session, so we thought, okay, you can all read the published literature. So in the second part of this meeting, I want to show you some case reports where we could go through. So 2 patients, I will present 2 patients who received treatment in our institution. And before I start, I want to pick up what Professor Baruchel mentioned. He said, okay, listen, there are different CARs, and that is very important, whether you do have a CD28 co-stimulatory domain, or whether you do have a CAR with a 4-1BB co-stimulatory domain, because the latter, they are able to persist long-term, really. And so we do have patients who were out of the CAR-T cells for more than 4 years, and they do have persisting T cells. And in my eyes, what could be done better for the patients with the leukemia to have an extremely specific treatment which lasts and should eliminate the disease. But we will have the chance to discuss this a little bit more in detail later. So now, how can I, these are my conflict of interest disclosures. I have research grants from Leuvi, RIMS and MEDAC. And here, with relevant for this presentation, is my advisory board task for Novartis, Celgene, and Amgen, and Milteney, I think. So I start with this case report of a boy who received the diagnosis of a common ALL treatment, and you see this in June 2012. So this is almost 10 years ago. He was born in 2001. So he is exactly 20 years today, or not today, but this year. So he was treated according to the frontline protocol, SIOPE 2009. And then you see he has a late relapse, first bone marrow relapse, and he received treatment according to ALL, a relapse protocol. And this was a time, for example, when we did not have had CAR-T cells in Europe available, but this was a standard treatment. So he received relapse treatment, and he did not even get a transplant by that. However, in the same year, he developed, or he showed that he is refractory to the chemotherapy. And although a late relapse without the fatal translocations or risk parameters, leukemia did not respond. So he received 1 dose of blinatumomab and then clofarabine, etoposide, and cyclophosphamide. And with that, we could bring him in hematological remission, and then we decided to do a transplant. And this was done in 2000 and in February 2015. So everybody, I think, agrees this is a standard process how to treat a patient with this disease, with a relapse in Europe these days. So this was in February 2015. But this transplantation was not easy. And this is the course of transplant in the first 11 months. So you see, we started here, 0 months, this was a transplant. Then the patient went into aplasia. He developed nicely with the green line and the yellow one. These are the T cells. And everything was nice. However, 2 months after, let's say at day 60, you see the red line, and this is minimal residual disease, started to increase again. So then we started at that time with our in-house immunotherapy, cytokine-induced killer cells. This was the first in man dose for this type of cells in this patient, and he received 1 dose, a second dose, a third dose, and you can see we could overcome and eliminate the minimal residual disease, which was quite high, almost 1%, almost overt relapse. And then this was month 11, and this was in February 2016. And this was great. So he received a transplant 2015. And then 3 years later, more than 3 years later, he presented again in our outpatient department and shortness of breath. And he has had some caput medusa on his belly. So we did a clinical checkup, and you could not hear his breathing sounds on the right lung. So we did an X-ray, and you see this. It was a pleural effusion, and we did a puncture of them, and you can see the thorax drainage. And in this, in the diagnostic puncture, you see, okay, this was all leukemia cells. So he has had an extramedullary relapse, and this is also interesting finding. If you do immunotherapy in patients and they do relapse, it's often the case that you can control the compartment where your effector cells are coming to, but not the outside compartment, as in this case, he developed this pleural effusion. So the bone marrow then, by the time, was MRD positive, and the CNS was negative. So this was a great point. So 2018, after 6 years of treatment, the patient has become 17 years old, a male patient with a common ALL, second relapse, 3.5 years post first transplant. So for those of you who are not very familiar with transplant and outcome results of patients who relapse after allergenic transplantation. So it's fair to say that these patients who do develop a relapse so late after first transplant, they have a fair chance to be rescued by a second allergenic transplantation. So the question now we have had to discuss with this patient, 17 years old, very smart boy. Do you want to undergo a second allergenic transplantation? And if so, shall we use again an unrelated donor, or would it be better to use a haploidentical donor? So you may know that we have a large haploidentical stem cell program, and have published a paper how to treat relapse after allergenic transplantation, and haploidentical plays a major role. Or CAR-T cell treatment if the relapse is still CD19 positive. However, and this is also a treatment option, and we published this in 2016 already, André Village from our group, in children who relapse very late after allergenic transplantation. Maybe this leukemia is not that aggressive, and you could successfully treat these patients also with a low-dose chemotherapy alternating with donor lymphocyte infusions for the transplant position of use. So these were the options which needed to be discussed. So my question to you is, what, and you are many, over 66 participants, what do you choose? How would you treat this patient? He is 17 years old, and he wants to draw the last exam in school, the baccalaureate, the Abitur, his A-levels, and this was in December. This was in December now, and he would have his exams to do in February. Would you go for a second allergenic transplantation? Would you use CAR-T cells? Would you propose to him the low-dose chemotherapy? Roloff.
I think if you can round it, then we can show the results.
So most of you, now this is the topic of the session, huh? So I have had the privilege to present this case a few years ago at a CAR-T meeting in Berlin. So this is controversies in stem cell transplantation meeting. And there were our internal medicine colleagues there, mostly, only a few pediatricians. So what did they choose? You see, almost similar as you. A second allergenic transplantation, haploidentical, 14 and 13% CAR-T cells. This was the topic of the session as well. So this was the treatment of choice, and 3% would have chosen in this particular patient the alternating treatment option. So what did we do? So we also tried to decide to go for CAR-T cell treatment. And now we face the same problem as you, Andre. Which bridging treatment should we use? And we have once in this how to treat relapse patients after allergenic transplantation, where we have this metric protocol, low-dose chemotherapy and DLI, developed a protocol which looks like low-dose idarubicin, vincristine, dexamethasone for induction for over 4 weeks, and PEG asparaginase. And this is how we are try to bridge our patients. In the first patients, we used the whole block because in the Eliana trial, as you mentioned, Andre, we have had to bridge the time up to 3 to 4 months often because there was no slot available. Now with the commercial available products, it's shorter. So we shortened this. And in principle, so if we have to bridge only 3 to 4 weeks, then we are using the idarubicin, vincristine, a short course of dexamethasone over 2 weeks, intrathecal treatment. And in some patients, not in all, we are giving asparaginase. Here it is also important to know, maybe it makes a difference, and we did not talk about it already, whether the patient who is in need for CAR-T cell treatment is a patient post-transplant, where the hematopoietic system might be less bearable of intensive chemotherapy. Yeah? So, okay, this is also an idea how bridging could be done. This is the Frankfurt protocol, so we call it. So we did this, and the patient was then admitted for the lymphodepleting chemotherapy, and he received excellent CAR-T cells. You see our lymphodepletion. So this is the basis we are using, 1,000 milligram cyclophosphamide, and in patient with a very stable hematopoietic system, we are going nowadays up to 1,500, and we are using 120 milligram fludarabine. So this is how we're doing it. So this patient received 2.3 times 10 to the 6 transduced T cells. And you see these CAR-T cells here in the peripheral blood. They are really proliferating, they are active, and this is very nice to see this. So lymphodepleting chemotherapy in this patient, T cells disappeared, and then at day 0, we gave the CAR-T cells, and shortly thereafter you see T cell expansion. However, patient did not develop fever, no CRS, no CRESS, and we could observe CAR-T cells in this patient for a while. For the first 100 days, and they disappeared. They disappeared. And he was followed up after day 100. Yeah? So there were no CAR-T cells available. A lot of T cells. This is the red lines, and then you see these purples. Huh? B cells are coming back over a period of 1 year. So we did wait and see, but check chimerism and did bone marrow in this patient, and only after 350 days he became MRD positive again, 1.5 times 10 to the minus 3. And we checked the bone marrow at this in October there, and you see this chimerism was still complete donor, even in the CD19, CD10 fraction at the time. So it was really very low leukemia. We repeated the bone marrow puncture 1 month later, and then you realize now leukemia increased, and you could detect this also with the chimerism in the subpopulations. And we have had to face the following problem. Now the patient is 1 year older, 18 years now, imminent third relapse, 4.5 years post first transplant, and 1 year after CAR-T cell treatment. So again, the question is what to do. Shall we give him a second CAR-T cell infusion? Or shall we now start a second allergenic transplantation? Or wait and see? So, so the second allergenic transplantation, so this is really important to know. And Henri mentioned this, we can cure many patients with allergenic transplantation nowadays, and we have proven this in our forum study, which was recently published. But the second allergenic transplantation has an even higher TRM rate. So you have to mention to the patient that 10 to 20% of all the patients, statistically, to whom you offer a second allergenic transplantation will die in remission based on toxicity. That's the statistics. So now this patient was at university, and he did not want to get out of his university and of his social life. So which treatment do you propose for this patient now?
Can we ask you to share the results?
So now it's less clear. It's less clear, and so we did not decide to go for a second allergenic transplantation because the patient did not want it. So we decided to give a second CAR-T cells because he has had 2 more of these bags in the freezer.
May I ask you, Professor, maybe someone has a question in between on this case, because this is quite a difficult decision what to do.
Yeah.
And I saw that Andisha is also pointing out something on pleural effusion. I don't know, Andisha, whether there's a question behind it as well.
I have 2 questions. In fact, why, Peter, was not the haploidentical transplantation an option for you?
It was an option for me. It was an option for me, and we discussed this seriously. You mean now for the second bag or for the in the first?
No, for the second, for this relapse now you're referring to at the moment. Where you decided now for a second CAR-T cell infusion. Why didn't you think about a haploidentical transplantation from father or mother?
Yeah.
For example, with post-transplant SI or something like that.
Yeah, there are different ways to do so, and I think this is a really valuable option, and we thought about it. And we discussed this really with the patient, and now he was 18 years old, and he was at the university. And I think, I'm a transplanter with passion, and I'm doing this for more than 30 years. But it's in fact true. First, you start TRM in patients. And this is now, we are very happy that in the first transplant setting with an unrelated donor or a haplodonor, we are below 10%. But in the second transplant, TRM statistically is between 10 and 30%, 30%, and especially in older patients. So, and even if you have the feeling, okay, this patient is in best general condition, it might happen. And then here you have to do an informed consent with the patients, and we did this. And I said, okay, now you have to take also a little bit of the responsibility for this decision. How do you see your life? And what has become clear, obviously, we can gain time as well, and we do observe progress in the field of treatment of patients with acute lymphoblastic leukemia. And definitely, in 3 years from now, we will have even more options. We will not have only this licensed Kymriah product now, but we will have other ones, better CARs, more effective CARs, dual target CARs. Andre mentioned this, armed CARs maybe. So yeah, it could also be an aim, even if you do not believe that the patient will be cured, but to gain a year more maybe. And that finally was also the reason for this patient and the family and for our team, that we together took the decision to go for a second CAR infusion.
Thank you, Professor Bader. I think there was one question of Daniel Drostov. Was this leukemia still CD19 positive? But
yes.
Giving the CAR-T, I assume it was.
This was.
There was another question.
This was not possible to check this because we have only MRD situation here, but he has B cells and we did not have CAR-T cells around any longer. So we clearly, that's an important point. That we could not prove this.
And I see another question from Laurens van, I can't see your full name. Maybe you can unmute yourself and pose your question.
Yes, my question is whether CAR T cell therapy with donor T cells is also an option, and maybe even T cells from the same donor who gave the first allotransplant.
Okay, this is a very complicated point. Yes, this is in principle an option if you do have access to. However, currently there is only one licensed product. This is this Kymriah, and this is autologous one. Yeah, you have to take this from the patient's T cells, which could be fully donor. But if you would have an option of a clinical trial where you could use allergenic T cells, yes, that's an option, but it is not allowed doing this for the T cell gene Leqvicel product.
Interestingly, we could think that this attitude could bring to a high rate of GVHD, and the Chinese people who have done it, and also Rupert in Tübingen who's done it, they say, and it was also done by on the West Coast, they say that the rate of GVH was extremely low, which is very strange, because when we use so-called CAR-T cell after relapse, after transplant, they are of donor origin. So it's kind of allogenic CAR-T cell, if you want, but they are tolerized. The idea to take it out of a donor who has grown up during the time, etc., you are dealing with real allogenic T cells, not tolerized. So the theoretical risk is GVHD, but with very few data on the table, it seems that it is not the case. So the idea is extremely interesting if we can have access to it, which is not the case.
That is right. And you have to imagine that the transduction efficacy here, there are only 30 to 40% max CAR-T cells in. Others are really activated allergenic T cells. And I think it's too early to say it's really sure, it's really safe to do so. And I fully agree to you.
I see that there are more questions, but shall we go for the time, continue with the case, and then propose further questions after?
Yeah. So you see the long follow-up from 2016 on your left, first infusion of CAR-T cells, up a recurrence of B cells here, and then the second CAR infusion, this was in 2019. Patients again did not have a CRS, complete remission, MRD negative, full donor, B cell aplasia, detectable CAR-T cells were there. for a long time. This was here in December 2019. And then to make this story shorter, after that, the patient developed B cells again, the CAR-T cells decreased, and then we gave him the third infusion of the CAR-T cells and are discussing now with the patient what to do. Exactly at the moment, he has only a few CAR-T cells and he is MRD negative. And we are discussing now whether to give him a consolidative second allergenic transplantation or whether we should use again these cytokine-induced killer cells. I mentioned this before. And there is now on the horizon a new CAR-T cell product, CD1922. Whether we should really try to maintain this patient in remission with other immunological therapy to hope to bring him there for a new CAR-T cell product. Patient still hesitating to undergo a second allergenic transplantation because he is feeling so well and is at university, and it's really, yeah, he's hoping for an easier treatment. And this, you have to see, this was in 2018, November, more than 2 years. For more than 2 years, this patient has had an excellent quality of life. He finished his school. He went to university. He is living in his own flat. He is independent, okay, and he's feeling well, and he's feeling great. So that's also a context we have to discuss when recommending treatment for patients.
May I propose, Professor Bader, that we see, I saw that Paula has another question, if people have other questions, and that we save the second case for another time?
Yeah.
Would that be okay?
That is very much, this is very much okay. I have prepared maybe one final slide, because the question was whether or not consolidate CAR-T cells by a second transplantation. And so I prepared this slide for discussion as well. I think second generation CAR-T cells are able to expand and persist. And my Frankfurt position is, as long as these cells persist and B-cell aplasia is present, we do not perform in Frankfurt allergenic transplantation for consolidation. In case of early B-cell loss or loss of CAR-T cells, and early means before 6 months post CAR-T cells, here I think it's fair to discuss this, and even I would agree if physicians and patients state to perform allergenic transplantation here in remission, that would be okay for me. And clearly, what's more difficult is loss of CAR-T cells beyond 1 year from CAR-T cells, whether you have to do anything at all or whether you could hope that CAR-T cells have cleared the disease. And then there is the CAR-T cells, the CD28 CAR-T cells, in whom you know that these cells do not persist long enough. So there it's definitive more complicated. And the US colleagues, they are introducing allergenic transplantation for consolidation. So, okay.
Maybe Paula, is your question in line with this? May I ask you to give you the word?
Yeah. So I have two questions regarding one regarding the case and one regarding this. So regarding the case, why did you decide not to go to the transplant, even though you may expect a recurrence later, but hoping we will have more treatments then? weren't you afraid of a CD19 negative relapse?
That's a good, it's really, this is really excellent points. And these are facts. You have to discuss this with the patient in detail. And this is a very clever boy, huh? And it might be different if you would have a younger child with a lower risk of TIM in a second allergenic transplantation, in a family who is not able to really realize what you are talking in details. So this is a smart boy, a clever boy, and he knows this might happen, CD19 negative relapse. He knows that the relapse might be so resistant that you can't treat it with T cells, nor with chemotherapy, nor with allergenic transplantation. So, but he said, okay, this is how I feel good in my life, how I want to continue. And I said, okay, I agree. I do not force you to go for a transplantation, and I also hope that he will be able to reach new treatment options. So this is one point, and the other is he still was only MRD positive. This was not an overt relapse, and to start a second transplantation on the basis of MRD positivity makes it even more complicated in my eyes, if you then at the end of the day realize that the patient develops a fatal toxicity or a fatal GVHD. André, what do you think? You have
these are extremely difficult points, of course, and it's true that the age and the understanding of the adolescent is one of the more difficult things we have to face. Just to give you 3 examples of non-persisting CAR where we wanted to perform transplant and where patients have refused. The first one is an adolescent with TEL-ML1 who have already 2 relapses at 4 years. Finally, now he's 15. We went to CAR 3 months after the infusion. Loss of B-cell aplasia, which means loss of CAR-T cell. So we say, okay, now you have had already 2 relapses. Now you have no more CAR. We need to transplant you. He said, no, it was 2 years ago. He's still doing well. Same with another adolescent, 13-year-old, more understanding that her parents, she totally refused for loss of B-cell aplasia transplant. She's now 3 years off. We have done to her the second infusion, didn't work also, no, but she's doing well. And we have another one like that. So I fully agree with what Peter have said. As soon as you have persisting B-cell aplasia, do not go for transplant. As soon as you lose it, look at the delay. If you are in the first 6 months, it's reasonable to propose a transplant. Patients will at the end maybe decide not to go to transplant, but it's reasonable at least to propose it. Above 1 year, it's probably the wait and see, which is the more reasonable attitude. Between 6 and 12, we have to discuss between us, depending on the biology of the disease, depending on the exact history of the children. So it's not so well stabilized field, I would say. And the case for reinfusion is also not a stabilized thing, because also you could argue that if your cells have not expanded and persist long enough, maybe you have to remanufacture other cells. Anyway, there are many, many possibilities.
Okay.
With that, I think I would like to very much thank you for your input in this topic and explaining the potential, but also the way to find collaboration with our patients and learn from each other what would be the best strategy, bringing them not only survival, but also their quality of life, where these development of new drugs really help also with. Thank you for outlining the difficult topics of today. I would like to thank all the participants for their input, their attendance, And I was just pointing out that we, of course, have collaborative Young SIOPE sessions at the SIOPE meeting end of April. There are some more educational webinars by the end of the year, focusing on CAR-T cells in pediatric solid tumors. And we'll continue with the ear and PETCAN Young SIOPE challenging cases in April. And we all welcome you to rejoin us there. Thank you all. Thank you, Paula. And I wish everyone a really, really good evening.